Hi guys, this is chapter 24 in your book. This chapter is regarding exercise for the older adult. So we're going to talk specifically about people over the age of 65 and how to properly prescribe exercise for them. So as part of the aging process, just a few numbers to kind of take a look at, which I will not ask you to repeat these numbers, but the average life expectancy in America is 76 years for men and 81 for women. About 13 to 14 of the current population is over the age of 65, and there are certain aspects of aging that we do expect to see in people who get to be a certain age. And part of that is a decrease in strength as well as a decrease in independence, which is can play a major toll. One big thing that I noted from your book was that there is currently a 117% increase in percentage of older adults, so over the age of 65, employed in the workforce. So people are living a little bit longer, but they're also working quite a bit longer. Not everyone can retire as they start to get older. So not only are we dealing with some of these age-related changes, but we're dealing with them and we have to get back to work or be able to work while we're dealing with those changes. So your book kind of breaks down the older population into three categories: the young old, which they classify as 65 to 74. These people may be recently retired. They may be caring for their own aging parents. They may also be the caregivers for grandchildren. They may continue to work. They may be retired. So they've kind of got a lot going on. Sometimes they refer to this as sort of like that sandwich generation where they're caring for people older than them and younger for them, possibly even at the same time. Then we get into the mid-old category, which is 75 to 84 years, where you're starting to really experience some more of those age-related changes. People are usually starting to sort of feel their age, may even require rest during the middle of the day. And then we get into the old, which is 85 and over, which is usually when we start to see a more significant decline in physical function. So APTA put out this Healthy People 2020, and it may not have even been completely them. I think they worked in conjunction with like the American Medical Association and some other health-related organizations to come up with Healthy People 2020. And the idea behind this was just to increase the amount of older adults with more healthy activity levels, because they have found that reduced physical activity can lead to things like reduced cognitive function, and that exercise can actually help to slow some of these effects. So of older people, they found that 29.3% have moderate to severe functional limitations, and that only 1 in 3 older adults engage in any type of regular physical activity. One thing to keep in mind too with our older patients is that 92% of older adults have at least one chronic condition. A lot of times that's going to be high blood pressure. I forget the exact number and it might be on a slide later on, but the vast majority of older patients are going to have high blood pressure. 77% have 2 or more chronic conditions. And then the more chronic conditions you start to pile onto someone, they all start to impact the quality of life. And then that can lead to sort of a downward spiral. 25% of older adults are describing their health as fair or poor. So they're even viewing themselves as not being in the best of shape. So again, with Healthy People 2020, the idea was to try to increase regular physical activity to help to counterbalance some of these effects of aging. So I know you guys have talked about the effect of aging on the different body systems. It was covered in fundamentals, but we're going to go over some of those now. There is a Latin word, it's senescence. It means to grow old. And so one thing we've noticed in the older population is something we call immunosenescence, which is just the decreased ability of the immune system to function the way that it should. So we see increased incidences of diseases like cancer, infection, autoimmune diseases. So as we age, we have the increased incidence to get sicker. We're seeing that now actually with COVID-19, right? That's affecting our older population a lot more severely than it is our younger population. At the cellular level, there is atrophy of the muscles and the brain. They've done lots and lots of studies on this, and Because of a lot of different factors, muscles will start to shrink and become weaker as we get older. The brain actually starts to shrink a little bit as we get older as well. We also will experience hypertrophy of the heart and kidneys as we age. With the musculoskeletal system, we start to see an overall stiffening of the connective tissue. So we see loss of elasticity of the muscles, the tendons and ligaments. Those are two separate words, which also occurs in the blood vessels, organs, the airway. So even things just as simple as like breathing, your heart pumping, those become more labored as we age as well. Organ reserve changes as well. So there's decreased reserves in the heart, the lungs, the kidneys. So organ function overall, just in general, slows down as well. So as far as the different systems go, we do expect just sort of natural aging related processes to happen to most of the systems of the body. So the endocrine, immune, integumentary, musculoskeletal, reproductive, urinary, cardiopulmonary, vascular, sensory, and CNS are all affected by aging. So I don't think there's any left, right? They're all affected by the aging process. And one thing that is noted is that most of those systems will improve with some sort of physical activity. With the neuromuscular system, we do note a loss of muscle mass as we age. How quickly that happens increases the older a person gets, and the more sedentary that person is, the more quickly those events are going to occur as well. This is happening because there's a reduced size and number of muscle fibers, especially the type 2 fibers. There's a decrease in neural activation. We talk about the CNS just sort of slowing down in general, and an increase in antagonist coactivation. By the age of 60, there's about a 50% loss of motor units innervating muscle fibers. So not only are we losing muscle mass, but they're losing some of their innervation as well. So they're not going to work as effectively. One of the big things that this causes problems with is gait. So where you see decreased speed, decreased stride length with gait, which can then lead to decreased efficiency with ADLs. Because people are then more sedentary, we see an acceleration of osteoporosis, osteopenia, and osteoarthritis as well. Sensory changes can have a big impact on function as well. Vision is one of those things, so difficulty reading prescriptions, filling out paperwork, peripheral vision decreases. Pair that with decreased mobility in the cervical spine, so then we have to start taking a look at driving safety. And then using bifocals. As we age, more and more people start getting prescribed bifocals because we not only maybe lose the ability to see far away, but then we start to lose the ability to see things close up as well. And so bifocals can help with that, but you have to adjust to being able to use those lenses to do both things. That can certainly affect gait, and that can increase the risk of falls. Also, because of decreased sensory input, and we've already talked about balance and gait and the systems that play into that, decrease the sensory input, decrease vision, all of those things can have an impact on gait and balance. So decreased activity, we know this is not a good thing, but immobility, such as bed rest, will negatively affect every system of the body. So some possible effects of bed rest include orthostatic hypotension, so significant changes in blood pressure when moving position, increased heart rate, decreased cardiac reserve, pneumonia, DVTs, PEs, those can all be life-threatening events. So again, just little bits of activity can be enough to combat some of those things. Bed rest will increase urinary retention, constipation, muscle atrophy will happen more quickly, contractures will start to develop more quickly, metabolic inflexibility, osteoporosis will develop more quickly. There's an increased risk for skin breakdown and depression. Hypokinesis, if you break that apart, low movement, so diminished muscular function or mobility. This is the term that we sometimes use to just discuss the trend of increased sedentary lifestyles. Sedentary behavior is now actually recognized as a modifiable risk factor for many illnesses. There's a lot of illnesses that can sort of be traced back to being sedentary, or at least adding some activity can be of benefit for a lot of different illnesses. Studies have shown that people who maintain a healthy weight are more likely to live 7 years or longer than those who are obese or overweight. So strength training for older adults. study was conducted and found that older adults who participated in strength training twice a week noted less difficulty with walking 3 city blocks, ascending 10 steps without rest, standing for 2 hours, sitting for 2 hours, stooping, bending, and kneeling, reaching overhead, grasping or handling small objects, lifting and carrying 10 pounds, and pushing or pulling large objects. So a lot of just daily activities. These people completed strengthening twice a week, and they were able to do these with increased ease as compared to people who did not perform any type of strengthening activity. So this is not the only study that's been conducted that shows the benefit of strength training for our older population. So this is probably one of my favorite memes ever. This is like my life goals. But anyway, one of the biggest problems with strength training the older population is that most programs are significantly underdosed. So I think people, therapists, doctors, anybody, trainers, they see an older person and they think, okay, well, we're just going to take it really easy. We're going to give them really light resistance. We're not going to give them very many reps. And there's times where that is absolutely necessary. However, what they have found is that most older adults are not actually being challenged by the exercise programs that they're given. So there's grandma doing some nice deadlifts and wondering what color TheraBand she's supposed to use, right? So anyway, physical activity will slow the physiologic changes of aging, help to optimize body composition, support their psychological health, cognitive health, and these are really important for our older patients. It can help to manage chronic diseases, decrease the risk of developing any chronic diseases or any additional chronic diseases, minimizes the risk of physical disability, and helps to increase the lifespan. So some considerations before we start prescribing exercises to our older patients. We need to know what sort of medications they're on. Most of them are going to come to therapy with a long list of their medications. And so we use the term polypharmacy, where they're using more than 3 or 4 types of medications. So they're usually on several medications to control those chronic conditions that they have. This can become a fall risk factor, especially if they are taking diuretics, antiarrhythmatics, and psychotropics. Those drugs in particular do tend to increase the risk for falls in our older population. There is a questionnaire. You can click that link, and it's a pretty short questionnaire actually that was developed, and it serves as a screen to help to determine if an older adult should be participating in an exercise program or not. So it just asks them a couple questions. They check yes or no boxes, and if they check so many, you might want to get them checked out by their physician before they start doing their exercise. Most of our older patients are sent to therapy from their physician, so we sort of take that to mean that the physician has cleared them for exercise. There are some objective measures that we can take with our patient to help determine either, are they appropriate for a strengthening exercise program, or what sort of program should we give them, or where should we start with our program. So things like hand grip. Hand grip has actually been shown to correlate pretty well to functional mobility and ability of older adults. So it's a quick, easy test to do, and there are norms out on the internet where you can look and see where your patient falls for those. The 5 times sit to stand test, we know that's a really quick and easy functional test that we can do to screen out for falls, timing how long it takes them to go up and down stairs. Power is lost more quickly than strength. Again, a lot of times we don't really correlate power with the older adult or think it's important to train power with them. We're not talking like huge powerlifting type things with the older adult, but they have to have enough power to lift themselves out of a chair to do sit to stand. So it's more of a functional power type aspect that we need to look at with them. We can also look at gait speed, really easy to do on a treadmill, right? Just have them walk on a treadmill, find a self-selected comfortable speed. What is that? We can do the timed up and go test, 6-minute walk test. We usually do that on the treadmill as well. Put them on a treadmill, let them pick their desired pace, have them walk for 6 minutes, record the distance. Retest them in a couple weeks. Hopefully they're able to walk a little bit faster, cover a little more distance, and then we can show progress that way. So exercise prescription for older adults. It should include aerobic activity, flexibility, balance, and resistance exercises. So in general, for most older adults, we want to give them a program that incorporates all of these different aspects. So as far as aerobic exercise goes, guidelines that we should follow with the older adult: understand max heart rate, which we talked about in the aerobic lecture. It's going to decrease with age because we can use that simple formula, 220 minus the age. So the older they get, the lower that number is going to become. In general, stroke volume from the heart is going to decrease with age. Maximum oxygen uptake is also going to decrease. And so we need to keep that in mind too. They're just not able to take in as much oxygen and use it efficiently as they age. Blood pressure is going to increase, and respiratory rate is generally going to increase as well. So the recommendations for aerobic activity for older adults is 150 or more minutes of moderate aerobic activity per week, which would be considered like brisk walking, or 75 or more minutes of vigorous intensity aerobic activity per week, which would be things more like jogging. The way that it's been described to tell a difference between vigorous activity and moderate intensity activity is moderate intensity activity, brisk walking, you could be carrying on a conversation while you're doing that. Vigorous intensity would be like you could only get out a few words at a time. So you're jogging, you can't hold a full conversation, right? You can say a few things, have to take a breath, can say a few more things. So that would be considered more vigorous activity. You can do a combination of both. So you can do a little bit of vigorous activity, a little bit of moderate activity, and you can also do short bouts at a time. So we certainly don't expect our older patients to go out for a 60-minute walk, once or twice a week. Break those time frames up and do just little bits at a time. And then that gets you more regular activity throughout the week as well. Flexibility exercise, for our older patients especially, a low intensity, long duration stretch is going to be most beneficial for them. They do have decreased tensile strength, and the tissues aren't going to respond to stretches quite the same way as they did before, so there is an increased incidence of tissue tear, so we do want to be careful with our stretching. However, we do want to make sure that we are addressing flexibility with our older adults, especially if they are getting more sedentary. Things are going to start to tighten up a little bit. That can lead to postural issues, and then just again into that downward spiral of more and more sitting around. Connective tissue can also be injured at lower levels of tissue stress with comorbidities such as nutritional deficiencies, hormonal imbalances, and dialysis, which again all increase as we age as well. So recommendations for flexibility exercises in our older population is to try to use that newly gained range of motion in functional activities. If that's something that they have to do on a daily basis anyway, they're going to continue to use that range of motion and we're more likely to maintain it. Encourage movement through the trunk, neck, lower extremities as much as possible. So again, ADLs that involve reaching and turning and things like that will help to use them on a regular basis as well. Balance training with our older adults, we want to make sure that they have good, adequate sitting balance before we move to standing. We always want to make sure that we have safety measures in place, especially if they're going to practice this at home or by themselves or with someone else. Again, challenge the patient, but make sure they're still going to be safe. We don't want to push our patients too hard that could potentially lead to a fall or anything like that. And then again, always try to incorporate functional activities when the patient can tolerate those. So things like sit to stand, heel raises, walking, sidestepping is a big one. We don't always think about that, but sidestepping to move out of the way, to avoid obstacles, reaching overhead, behind the back, each side to the floor. So again, with the balance activities, encouraging our patients to do some reaching. So even things like ball tosses, balloon tosses, make sure they have that reactionary control and make sure you're challenging them, again, with being safe at the same time. So recommendations, Tai Chi has been shown to be very beneficial for our older population as far as balance and flexibility training goes. As little as 15 to 20 minutes per day is usually enough to start to see benefits from this type of training. And again, you can always progress to more challenging activities as the patient starts to improve. Balance is something that as you train, you should start to be able to notice pretty decent improvements in a relatively short amount of time. And then again, resistance exercise. So again, this is really important in helping to maintain independence. which is really important for our older population. Loss of independence is huge for this population. It's one of the scariest things for them to start to think about. I remember when my grandmother was getting older, she lived to be 92. She lived by herself the entire time that I knew her. But that was one of the biggest things for her, was when she lost her license or lost the ability to drive, because that was a huge loss of independence. She couldn't go and do the things that she wanted to when she wanted to anymore. So even though she still lived by herself and was independent, and taking care of herself and things like that, that was a big blow for her, and that was a lot for her to handle. So again, strengthening can help maintain that independence. It can also help as they're recovering from pathologic conditions. So things like hip fractures and replacements and knee replacements and anything that can happen. The stronger they are, the more likely they are going to be able to become independent after they recover, or that they will recover in general. High intensity progressive resistive exercises have been demonstrated to be safe in older adults up to 96 years old. That's huge. We can do high intensity resistance exercises safely with people up to 96. So again, don't be afraid to give your patients strengthening exercises. Don't kill them with the exercises, but don't be afraid either. Go ahead and challenge them. It's okay for them to be challenged. Again, the programs that we give our older adults should be pretty much the same that we would give a younger adult. We do need to take into consideration a little bit more safety with this population. We may need to modify a little bit. They might have like arthritis in their hands and it hurts to hold a dumbbell. So let's figure out another way to do it. And then in general, we just typically progress a little bit slower with this population as well. Safety is a concern. So again, we want to try to supervise to prevent overtraining or exercising above their current fitness level. We want to make sure that they're using normal breathing patterns when they're strength training, again, avoiding Valsalva and that increased intrathecal pressure, especially because they probably do have a chronic condition or two where that's probably not the best thing for them to be doing. We want to work within pain-free ranges. So keep in mind, they might not have full range of motion to all their joints, but that doesn't mean we can't strengthen them within the range that they do have. Also, once the patient leaves the facility or is discharged, we want to determine, are they going to continue to exercise at home? Will they be using a fitness facility? Because then we can gear a home program based on where they'll be performing it. So determining the amount of exercise. This is the same that we would use for a younger person. So as far as resistance training goes, if they can perform 8 to 15 reps correctly, that's probably where we want to be. If they can't even perform 8 repetitions, then we need to decrease the resistance. It's too heavy. They're not doing it properly. If they've done 15 and they just keep on going, we need to increase the resistance. How many times have you been in the clinic and your patient's laying on a mat table doing their exercises, and let's just say they're doing short arc quads, and they've been prescribed the traditional 3 sets of 10, and the patient goes over there and they just sit there and they do all 30 at one time and they tell you they're done. They just did 30 repetitions of the same exercise. We need to increase that resistance. It was too easy. If they're supposed to be doing 3 sets of 10, by the time you get to 10, you should really want that break. It got heavy. You needed to stop at 10, rest for a little bit, and then resume the next set of 10. So if they can blow through all the reps at one time, that exercise is way too easy, and we either need to progress the exercise itself or we need to add more resistance to that exercise. As far as sets go, 3 sets is usually considered optimal with 1 to 2 minutes of rest in between each one. Frequency, 24 to 48 hours of rest between training sessions. Again, especially with resistance exercise, we don't want to strength train the same muscle group back to back. So make sure we're taking breaks in between. And if your patient is going to be seen daily, make sure that you're alternating between the muscle groups that you're working. As far as the speed of exercise, and that's where power comes into play, we want the patient to be able to perform at least 3 sets of the exercise before we add a power component to it. And then if you are looking to add the power component, add more rapid movements with light resistance to start to work on that. So some common disorders and exercise recommendations. So these are going to be common disorders that we see in the elderly population, and then what the exercise recommendations are to treat those disorders. So we're going to talk about falls, osteoporosis, sarcopenia or frailty, osteoarthritis, obesity, cancer, type 2 diabetes, and urinary incontinence. So fall risk. We know that increases as a person ages. 1 in 3 older adults fall each year, and 20% of those falls are going to result in serious injuries. There is a significantly higher incidence of falls in institutionalized elderly, so those that live in skilled nursing facilities or other types of personal care homes. On page 963 in your book, there is a chart, sort of an algorithm, that you can run through with your patient to sort of determine how high of a fall risk are they. When someone has been determined to be a fall risk, we do want to prescribe them a multidimensional exercise program. So again, that's taking into account resistance, balance, flexibility, strength, gait. We want to make sure that we're addressing all of those areas. We want to make sure that we're correcting any environmental hazards, just even little things like trying to pick up throw rugs. Yes, they look cute, but they're a tripping hazard. Having your patient put in night lights. A lot of older adults have to get up in the middle of the night to go to the bathroom. So even though it's their house and they're familiar with it, having that night light to just light up the pathway there a little bit so that if they forgot to put a pair of shoes away before they went to bed and now they're sitting in the middle of the hallway, they won't trip and fall as they go to the bathroom. Also make sure that they're wearing proper appropriate footwear, that's not going to lead to any issues with falls. Again, about 50 hours of challenging exercise. So about 2 hours a week for 6 months is needed in order to see changes. So again, that's why patient education and home programs are so important, because insurance companies are not going to pay for your patient to come to therapy for that long. So fall prevention, things that we can do to try to help these patients are resistance exercise. So leg weakness can be a contributing factor to falls. So work on strengthening of the lower extremities, include some power training once they've got some sort of baseline strength. Core strengthening, Pilates can help with that. Tai Chi has been shown to be very beneficial for balance and just flexibility, mobility in general. So this is different postures and gentle movements. There's some deep breathing and mental focus in there as well. That can help to improve pain, sleep, and anxiety. And then balance training, again, is going to certainly help with fall prevention and progress them and challenge them as they're able. So osteoporosis, we've talked about. This does affect women more than men. They're going to lose approximately 30% of their bone mass by the time they're 80. Remember that picture I showed you in the spine chapter of that thinning bone? That's crazy. And so what this can lead to is falls and or hip fractures. So hip fractures result in a 25% increase in mortality in 1 year. That's big. 25% are going to require some sort of long-term care following a hip fracture, and the remaining 50% don't always attain their pre-hip fracture status. So they may need to continue to walk with an assisted device. They may not gain full independence back after this. So we want to really try to minimize the risk of fracture with these patients. So we do want to do strength training, weight-bearing exercises for sure, and postural extension. Remember, we want to avoid trunk flexion. Because increased flexion is going to significantly increase the force on the vertebrae, which are already potentially weak. Weight bearing is going to stimulate the osteoblasts, and resistance exercise will do this as well. So weight bearing at least 3 to 5 times a week, resistance at least 2 to 3 times a week. This picture is showing this woman is wearing a weighted vest. So we start slowly, about 5% body weight, and then we increase from there. This is just a way to sort of get the patient weight bearing a little bit more than usual to start to build up some of the density of their bones. Sarcopenia or frailty. Sarcopenia is the loss of muscle mass beyond what's considered normal for age-related changes. So it affects about 30% of adults over the age of 60 and 50% of adults over the age of 80. So again, regular exercise, increased protein intake, because that is something we haven't talked a lot about yet, but as we age, nutrition tends to slide a little bit. Adults, maybe it's just 2 people living together, maybe it's even just 1 person living together or living by themselves, and it gets hard. You know, I don't want to cook a whole meal for just me. right? Some of you may have experienced that, and you had a bowl of cereal for dinner the other night, right? Because you didn't feel like cooking. It's just going to be you eating by yourself. So as we age, this tends to happen. Somebody's living alone, they're not going to go to that effort. So nutrition can start to decline for that and a whole bunch of other reasons, different disease processes, changes in sensory, right? Things don't taste exactly like they used to. So because of this, again, we want to make sure that our older adults are getting enough protein on a regular basis. We can also see what's called sarcopenic obesity. We need a DEXA scan or an MRI in order to diagnose this, but this is a disproportionate amount of muscle mass to fat tissue. So you see typically the larger belly, the person is overweight, and they don't have a lot of muscle mass to support that either. So again, for these patients, all types of exercise is going to be beneficial. With osteoarthritis, which we have talked about, we've covered osteoarthritis in almost every chapter that we've gone through with the joints. It's going to affect about 30 to 50% of adults over the age of 65. So a lot of our older adults are going to experience arthritis in at least one joint somewhere. The greatest incidence is going to be in the knees and then the hips, but then the hands and hands are also pretty frequent. The lower extremities are going to be more debilitating, less weight bearing, less ability to perform ADLs. We start to see those effects a little bit faster. So again, we need to educate the patient on the importance of exercise. Exercise can actually help to manage pain. Most people don't realize this or believe this because they start to think, well, my knee's really hurting today. I'm not going to go for a walk because that's going to make it worse. But lots of studies have shown that just even a little bit of activity has shown to help decrease pain. We want to do strengthening activities, stretching, balance, aerobic exercise during the less painful times, and about 130 to 150 minutes per week has been shown to have an impact on pain, quality of life, ADLs, the ability to decrease fatigue, and improve range of motion. We do want to avoid vigorous repetitive movements, especially if it's an unstable joint, and any joint affected by arthritis is going to become unstable at some point. Do keep in mind that if there is arthritis in their hands, it may limit the grip of free weights or TheraBand. So again, we just have to find other ways to work those areas or to apply our resistance. Observe their alignment and performance in response to exercise. We may need to modify exercises if they're having a lot of pain. Avoid any exercise that makes their symptoms worse. So continue range of motion and balance. If strengthening is too much for today, that's fine. And emphasize moving all joints through their full range of motion every day. So get up, do some stretches, do some exercises, and then get on with your day. Obesity. So we all know how important exercise is here, but a third of the adults over the age of 65 are now obese. This can compound other problems, just make other things worse. Abdominal adipose is predictive of health problems or other health problems. So that's why if you've ever done like a wellness checkup, or sometimes they'll measure just your waist circumference because they have actually found that that can be pretty predictive of other health issues. So things like development of diabetes, cardiovascular disease, sleep apnea, hypertension, and impaired respiration. Neck circumference can also be measured. That can be used in conjunction with waist circumference to sort of predict certain diseases, and sleep apnea is one of those that they're using neck circumference for. So you may need to assess your patient's BMI or waist circumference. I know there was a period in time, I don't think they're doing it anymore, but Medicare was actually requiring therapists when new patients would start to assess their BMI and give them information about that. Like I said, I don't think we have to do it anymore, but we were doing height and weight and calculating BMI and giving patients handouts. We want to observe them during physical activity and make sure that we're not overtaxing their breathing because of some lung restrictions that start to develop. Especially with obesity, we have more soft tissue pushing up on the diaphragm and the lungs, so the person is going to have a decreased lung capacity. Aquatic therapy may be beneficial. Because the person is obese, they are more likely to develop arthritic changes, and with that, it's going to make it more painful and difficult to perform activities. We may need to do some seated exercises as well for the same reason. It hurts to weight bear and load those joints. But again, physical activity is going to be essential to try to manage the symptoms of obesity. Cancer, we do tend to see a little bit more in cancer as we age. The median age for all cancer types is about 68 years. Nutrition, inactivity, excess weight can all contribute to the risk of developing certain types of cancer. There are certain sites in the body where if cancer is going to metastasize, it tends to metastasize to these sites. And that is bone, the lymph nodes, lung, liver, and brain. Breast cancer, lung cancer, and prostate cancer are more likely to metastasize to bone. So bone pain should never be ignored. And if there is cancer in the bone, then those bones are absolutely at more risk for fracture. Another quick story here, but I had a great aunt. It was my mom's aunt, who was, again, this feisty older lady and was of the belief that, she did not regularly need to see a doctor and things had to be really, really bad for her to go to a doctor. Well, she started experiencing some hip pain and it was just getting worse and worse and worse and worse. So she finally decided to go and see the doctor. And here they found out that she had bone cancer. She had cancer in her hip bone and that's what was causing her pain. My guess is that this aunt was also a lifelong smoker. And so my guess is that she probably had lung cancer and then it metastasized to her bones after that. Again, bone is one of those sites where it tends to metastasize, especially from the lung. So by the time they found it, there was cancer throughout her body. We do need to know or be familiar with several lab values when you're working with patients who have an active diagnosis of cancer. So we do want to be aware of their hemoglobin levels because that can present as fatigue. They can be very fatigued if their hemoglobin levels are off. And so we probably don't want to exercise them during those times. Platelets, white blood cells, INR, hematocrit. Your facility may have specific levels that you need to follow. So again, just be aware of where your patient's levels are and then whether or not that's going to preclude them from therapy. A low white blood cell count may predispose them to infections as well. So if they don't have a lot of white blood cells to fight things off, then we need to be careful about exposure with them. As far as exercising with cancer, they have found that 150 minutes of moderate intensity aerobic activity can prevent a cancer reoccurrence, also maintaining ideal body weight, decrease the risk of colon, breast, lung, and prostate cancers. So again, by doing a little bit of exercise, that may help us to maintain a healthier body weight, which can hopefully, again, help reduce the chance of these cancers coming back. So rehab can be successful at reducing the effects of pain, fatigue, strength loss, decreased cardiovascular capability, lymphedema, depression, anxiety, osteoporosis, and even nausea. Type 2 diabetes, those patients may need clearance to exercise due to comorbidities that we see with that, things like coronary artery disease, uncontrolled diabetes. If there's more activity than just brisk walking, which they consider anything more than 3 miles per hour, we want to be a little bit careful with that. So we might want to start with low-level exercise and then monitor if we can't do stress testing. One thing we do need to be careful with is that when we are adding exercises to their program, we have to have them monitor their blood glucose levels so that we don't have them bottom out, right? Especially if they're not used to doing exercises. So we want to start slow and gradually build our way up. So we want to avoid exercising when their insulin is peaking. Have them try to exercise at the same time each day so that way we can time it with their meals or time it with their insulin and to make sure that they're not having any negative effects from exercise. Wherever they're applying or injecting their insulin, be careful about using those muscles where you're exercising. Make sure they're maintaining hydration. Keep in mind too, hypoglycemia can occur even up to 48 hours after exercise, so have them continue to monitor their blood glucose levels even when they're done exercising. Also, assess their feet for sensation. See what their sensation is like because that can become a safety factor with your exercises, as well as balance and fall risks for that patient. Some patients with type 2 diabetes may be prescribed an infusion pump, so they can actually program their exercise times into the pump so that that can help to regulate their medications. Again, they still need to monitor their blood glucose levels before, during, and after exercise to see what sort of effects their exercise program is having on that. If they're going to exercise longer than 30 minutes, they should include extra carbs in their diet. Insulin may need to be decreased after exercise, and just watch for any irritation near the infusion site. Again, management of type 2 diabetes should include exercise, diet, and medication, and a combination of aerobic and resistance exercises are going to be your most effective for this patient population. And finally, urinary incontinence. This affects up to 46% of older adults. This is not a normal part of the aging process. As we age, we do not necessarily start to pee our pants, right? There's usually some other pathological things going on if your person is experiencing urinary incontinence. So there's a couple different types of incontinence. One is stress incontinence, which is just a weakness of the sphincter muscles. So you see lots of commercials on TV for both this and for the overactive bladder type. But stress incontinence, again, because all the muscles in the body are starting to atrophy and get a little bit weaker and lose their flexibility, your sphincters that control your bowel and bladder are muscles too. So the same thing is happening to them. So stress incontinence means that the person's going to pee or leak a little with coughing, sneezing, straining when they're putting stress on those muscles. The muscles aren't just quite strong enough to retain the urine that way. Urge incontinence is when they feel like they have to go to the bathroom a lot more often. So they may or may not actually have to, but they're getting that sensation that, oh, my bladder's full, I need to go to the bathroom. And then there's also mixed incontinence, which is a little bit of stress incontinence with some urge incontinence as well. There's also what we call functional incontinence, which means everything's fine with the patient, but because they have decreased mobility, they just can't get to the toilet in time. And so that is absolutely an area that we can work on and focus on in therapy. So we can do pelvic floor exercises, strengthening activities, which will help the strength of the sphincters and should help with some of the stress incontinence. And then functional mobility training can help with the functional type of incontinence. All right, so there was exercise for the older adult. Hope you enjoyed that one, and I'll see you next time. Thanks.